So here we're going to talk about some things that you'll definitely want to be aware of if you work with children. These are disorders of fructose and galactose metabolism. Once again, very, very important that you have some basic understanding of the metabolic pathways that go on, because it's going to make it much easier to understand these disorders when some of the symptoms are seemingly unrelated to one another. We're going to briefly review fructose and galactose pathways, how these converge and go into glycolysis, which is ultimately the goal of getting fructose and galactose. We want to turn it into something we can use. Either that goes into glycolysis, or we can take that and turn it into glucose and store it as glycogen. We'll talk about two disorders of fructose metabolism and two disorders of galactose metabolism. Two of these disorders are relatively benign. The other two are very significant and require immediate intervention if you want to preserve the patient's quality of life or their life in general. All right, so let's start with fructose metabolism. So when we ingest fructose, where do we get fructose from? Well, it's in its name, fructose, fruits. We get it from fruits, fruit juices, and so we ingest fructose. It's absorbed into the bloodstream, goes into cells, where it is then converted to fructose 1-phosphate. Fructose 1-phosphate is then converted through an enzyme that's the exact same, really, as the enzyme that breaks down fructose 1,6-bisphosphate, which, remember, is one of our products of glycolysis. The only difference is, while fructose 1,6-bisphosphate, as you know, will be broken down into glyceraldehyde 3-phosphate and DHAP, which are two 3-carbon molecules, the fructose 1-phosphate will be converted into DHAP and glyceraldehyde. So that's the difference, is that we don't have a phosphate on the glyceraldehyde because we only have one phosphate to begin with. So that phosphate goes to DHAP. On the other hand, with fructose 1,6-bisphosphate, we have two phosphates, so we can have DHAP and glyceraldehyde 3-phosphate. That glyceraldehyde that we get out of fructose 1-phosphate is easily converted to glyceraldehyde 3-phosphate, and then that glyceraldehyde 3-phosphate continues on through glycolysis. All right. Now, we're not talking about the pentose phosphate shunt here, but there is a way that you can skip fructose 1,6-bisphosphate and go from glucose 6-phosphate through a number of steps, a few of which are irreversible, to glyceraldehyde 3-phosphate and then continue on glycolysis that way. And the significance of that is that if there's an enzymatic defect anywhere along the way from glucose 6-phosphate to fructose 1,6-bisphosphate, it's not going to significantly interfere with glycolysis because there's a way around it. And you might notice here G6P dehydrogenase, that's G6PD, and that plays a role in a very important disorder, which we're not going to talk about here. Galactose metabolism, so where do we get galactose from? We get it from milk, primarily from milk and dairy. And galactose is one of the constituent sugars of lactose, which comes in milk as well. And so galactose is immediately broken down into galactose 1-phosphate, not really broken down, it's phosphorylated to galactose 1-phosphate using an enzyme called galactokinase. Kinase just means it phosphorylates, so it phosphorylates galactose. From galactose 1-phosphate, we have a very interesting mechanism here. So there's a phosphate on the galactose, and then there's a sugar that has a UDP, and that's UDP glucose. And there's this enzyme called GALT. And all it does is it transfers, it exchanges the UDP and the phosphate. So we go from galactose 1-phosphate to UDP galactose. It gives up its phosphate, takes the UDP from glucose, and the UDP glucose gives up its UDP and takes the phosphate from galactose. So they're basically switching dance partners. And so then we're left with glucose 1-phosphate, which can go into glycolysis after it gets converted into glucose 6-phosphate through an enzyme called phosphoglucomutase. And the UDP galactose can get switched into UDP glucose, which can then go into glycogen storage. All right, so let's talk about some of these fructose disorders. So the first one we're going to talk about is essential fructosuria, and this one is clinically relevant in as much as you can get some abnormal lab findings, but this is an asymptomatic disorder. So essential fructosuria is a deficiency of the enzyme fructokinase, which converts fructose to fructose 6-phosphate. Remember, that's the very first step of fructose metabolism. Like all of these enzymatic disorders, it's autosomal recessive, so both parents have to be carriers. Dietary fructose, because it can't get converted into a form that your body can use, it's going to remain in the bloodstream and it's ultimately going to be excreted through the kidneys quite easily. So you'll have fructose in the urine and some fructose in the blood, but it really doesn't matter. It's not going to affect the person at all. So they're going to be asymptomatic. They'll just be peeing out fructose. So this tends to be discovered incidentally. If you're getting a urinalysis and you look for reducing substances, well, you will have reducing substances because you have fructose in the urine. That's it. That's all it does. There's no symptoms. This is a coincidental diagnosis. Okay, so where does this happen? It is right here. So you have a fructokinase deficiency, you can't convert fructose to fructose 1-phosphate. And so you can't use any of that fructose as energy. So you might drink a glass of grape juice, you have fructose in that, and that fructose is just going to get urinated out. I imagine it might be possible that if these people have a diet really high in fructose, since all that fructose gets urinated out, they aren't going to be using those calories, and so these people may be a little thin, but I'm not sure about that. So fructose gets peed out. Otherwise, no problems with this disorder. Now this stands in stark contrast to hereditary fructose intolerance. These are two very different disorders. Okay, two very different disorders. Essential fructosuria, no symptoms. Hereditary fructose intolerance, lots and lots of symptoms. So this is a deficiency of the enzyme fructose 1-phosphate aldolase, commonly known as aldolase B. And this plays two very important roles. It converts that fructose 1-phosphate, which we talked about as a product of fructose metabolism, converts that to glyceraldehyde and DHAP, dihydroxyacetone phosphate, in the fructose metabolism. And then it also converts fructose 1,6-bisphosphate, which is a product of glycolysis, and it converts that into glyceraldehyde 3-phosphate and DHAP, and these work both ways. And that is plays a role in glycolysis and in gluconeogenesis. Okay. This is also an autosomal recessive disorder. So the problem with this is that you have fructose 1-phosphate. Comes in from the fructose goes into the liver, it gets converted into fructose 1-phosphate, and that happens in the liver and in the kidneys. Now if you can't convert that fructose 1-phosphate into something you can use, namely glyceraldehyde and DHAP, then that fructose 1-phosphate is going to remain in the liver and the kidneys, and you're going to get liver dysfunction and renal dysfunction. And so that is the problem in this disorder. We have renal and hepatic dysfunction. The presentation. So normally and this presents in childhood, when a baby is drinking breast milk or formula, there's no fructose in that. And so this will remain asymptomatic to start out with. But then the baby starts eating fruits and vegetables and table food, and there's fructose in that. And now there's going to be problems because that fructose gets converted to fructose 1-phosphate, and that fructose 1-phosphate has nowhere to go, and it's going to cause renal and hepatic problems. So the initial symptoms then will emerge once the child starts eating table food. And they can get jaundice and hepatomegaly from the renal dysfunction, vomiting, lethargy, and seizures, and that all has to do with hypoglycemia. And hypoglycemia is a symptom, it's a sign of hereditary fructose intolerance. Why do they get hypoglycemia? It just has to do with enzymatic issues. the fructose 1-phosphate that accumulates will actually, since the body thinks that that's a product of sugar metabolism, it's going to think that there's plenty of sugar, and so it's going to stop the process of gluconeogenesis because it thinks we already have enough sugar. There's all this fructose 1-phosphate. Why make more sugar? So it stops gluconeogenesis. It stops the breakdown of glycogen, and so there's going to be less glucose getting out into the bloodstream, and that's why this is a fructose-induced hypoglycemia. So they get vomiting, lethargy, and seizures. Those are all symptoms of hypoglycemia. So jaundice, hepatomegaly, vomiting, lethargy, and seizures. And they can also ultimately get renal dysfunction as well. Okay, so where's the problem here? The problem is going to be with aldolase. And so they cannot make these products which can ultimately go into glycolysis, but also the problem is that this fructose 1-phosphate is building up, and it's screwing up your ability to do gluconeogenesis and glycogenolysis. Now, we don't so much have a problem with making ATP, and that is thanks to this pentose shunt. So we have an enzymatic defect here, and you would think if it wasn't for this pentose shunt, you wouldn't be able to continue glycolysis, and that would be true, you wouldn't. But because we can convert glucose 6-phosphate ultimately all the way down to glyceraldehyde 3-phosphate, we can work around this shunt. And so the red blood cells will be okay. They can make ATP. And so we don't have a problem with making ATP. Our problem is primarily with fructose 1-phosphate being stored in large quantities in the kidney and in the liver. And then also that serious problem with fructose 1-phosphate inhibiting gluconeogenesis and glycogenolysis. Okay, so what do we do for workup? Well, of course, if the patient appears hypoglycemic, we're going to get a finger stick glucose. These patients typically are yellow, so we're going to get a CBC looking at possibilities of liver infection or some kind of disorder there. We'll definitely get a BMP, we'll get a lactic acid, uric acid, liver function tests, and a urinalysis. That will be our basic workup for a patient that presents like this. And of course, if they're seizing, you might get a head CT. That'll, of course, come back negative. But the finger stick glucose is going to be very important because anytime a patient has hypoglycemic seizures, one of the quick ways you can reverse it is by giving them glucose. So how is this going to come back? You're going to have hypoglycemia, of course. The CBC should be within normal limits. The BMP may demonstrate a metabolic acidosis. There's a variety of reasons for this. First of all, remember that you can get renal dysfunction. One of the ways that the kidney is going to dysfunction is going to be a Fanconi-like syndrome. And so you're going to be wasting bicarb, and that's going to cause metabolic acidosis. Another reason that you can get metabolic acidosis from this is that you get a lactic acidosis because of the, I don't have it here, but if you look back to that glycolysis pathway, you have an enzymatic block, and so you can get a lactic acidosis because of that block. There's impaired gluconeogenesis here, and so that's going to impair your ability to detoxify lactate in the liver. So remember, in gluconeogenesis, one of the things with gluconeogenesis that it does, in addition to making glucose, is that in the liver it can actually take lactate and convert it back into glucose. And that's not necessarily important for making glucose so much as it's important for getting rid of lactate. And so if this enzyme is not working, you're going to have some impaired gluconeogenesis and you're going to be at risk of lactic acidosis. Since you have lactic acidosis to some degree, that's going to compete with uric acid for excretion through the kidneys, and so that's going to cause you indirectly to have an elevated uric acid. There's another reason why you're going to have an elevated uric acid. These patients, because they're hypoglycemic, they're going to have an elevated level of AMP because they're not making quite as much ATP because they're hypoglycemic for reasons we already talked about. Because they have elevated AMP, that is going to induce purine breakdown of these molecules. And whenever you have purine breakdown, one of the byproducts of that is uric acid, and so that is another reason why they get uric acidosis. So lactic acidosis and uric acidosis. Their liver function tests will come back with elevated liver enzymes because of hepatic damage, as well as an indirect hyperbilirubinemia. The urinalysis will show reducing substances because of the fructose, the excess fructose that gets backed up into the bloodstream, and then signs of their kidney damage, the proteinuria and glucosuria being wasted through the kidneys. When you suspect hereditary fructose intolerance, the confirmatory test, it's a molecular genetic assay. We're looking for the gene LDO-B, which is the defected gene in hereditary fructose intolerance, and that should come back as mutated. What do we do to manage these patients? Well, it's pretty simple. We just want to make sure that they're not getting any fructose in their diet. And you get fructose from fruits and vegetables. You can also get it from sucrose, which is table sugar, as well as sorbitol, which you get a lot of in like the like gums, like chewing gum. They put sorbitol in that, and that's just the alcohol of fructose. So you want to eliminate all these things from the diet because of the possibility, or because of the fact that this is going to cause fructose 1-phosphate accumulation, causing the hepatomegaly, and it's also going to induce a hypoglycemia. You can refer these patients off to a biochemical geneticist for molecular testing, but if you know to get the LDO-B assay, you can just do that yourself. Complications, of course, hypoglycemic seizures. They can get intellectual impairment due to hypoglycemia if these episodes are severe or they have enough of them. And if this goes on long enough and it's not diagnosed, their liver damage can become permanent. All right, so not something to mess around with. Okay, now 2 disorders of galactose metabolism. We're going to talk about galactokinase deficiency and classical galactosemia, otherwise known as GALT deficiency. So galactokinase deficiency is a deficiency, of course, of galactokinase, which is the first enzyme in galactose metabolism. It's where we convert galactose to galactose 1-phosphate. This is an autosomal recessive disorder, and the presentation of galactokinase deficiency is quite simple. It's cataracts in infancy. There's lots of reasons that an infant may have cataracts. One of the first things you might think of is some of those torch infections, and that would certainly be one thing to think of. But one of the other things you want to think of is galactokinase deficiency. It's not terribly uncommon, about 1 in 50,000. The most common one that we've talked about, though, in all of these is the hereditary fructose intolerance. That's about 1 in 25,000. But galactokinase deficiency is about 1 in 50,000. There's an increased incidence in Eastern Europeans as well as the Romani population, otherwise known as gypsies. They have a slightly increased incidence as well. So cataracts in infancy, that's the sole symptom. And this will typically happen pretty early on because if they're breastfeeding, there's going to be galactose coming in from the breast milk. So this will happen pretty quickly. The workup for this is pretty simple. Since they don't have any other symptoms other than cataracts, the only thing you can really do to test them is to test their urine for reducing substances, and that will be positive because there's galactose in the blood. The confirmatory test is to get a blood assay of galactokinase, looking for that enzyme. That should be low. And the management is to just eliminate galactose and lactose from the diet. So put them on a lactose-free or galactose-free formula. This tends to get better as they get older. I guess the reason behind that is that the galactokinase levels just go up as they get older, and so they can tolerate that galactose. But this is really a problem in infancy. If you don't eliminate the galactose from their diet, they'll continue to get these cataracts. Why do they get cataracts? I mean, you think galactose, why would that cause cataracts? The reason behind it, actually, is if you go here and look at where this disorder is, you're going to have galactose accumulating in the blood, right? And that galactose is ultimately going to get to the aqueous chamber in the eye and the lens. And that galactose is going to get converted into galactitol, which is an alcohol form of galactose. And galactitol is not very water soluble. The enzyme that does that is called aldose reductase, and it exists in the eye. And so it will convert that galactose into galactitol, and that's going to yield this sort of cloudy fluid, and that's why they get these cataracts. They're made out of galactitol. And so this is where our enzymatic block is, and so it just causes galactose to accumulate in the blood. That's all. Okay, now this stands in contrast. Oh, here's our cataract here. Okay, and you will notice this cataract even when you're not shining a light into the patient's eye, and that is important that you note that, because on the other hand, something like a retinoblastoma, you'll only notice it when you shine a light into the patient's eye. This cataract, you'll notice it even when there's no direct light shining into the eye. Okay, so classic galactosemia is totally different. Okay, so kind of think of it, the relationship that hereditary fructose intolerance, very severe disorder, very serious, compared to essential fructosuria, which is basically not anything to think about at all. Consider the same relationship between classic galactosemia, which we're talking about here, and galactokinase deficiency. Okay, one is really a benign disorder, no impact on their life expectancy, it's not going to kill them. Classic galactosemia, on the other hand, can be deadly. Okay, so this is a deficiency of the enzyme galactose 1-phosphate uridyl transferase, otherwise abbreviated as GALT. And what this does is it exchanges the UDP and phosphate between the galactose 1-phosphate and the glucose the glucose UDP glucose. And so it'll exchange those dancing partners. And so you'll go from galactose 1-phosphate and glucose UDP to galactose UDP and glucose 1-phosphate. Okay. The result of this, since you're not going to be able to, here's the block, since you're not going to be able to convert galactose 1-phosphate to UDP galactose and UDP glucose to glucose 1-phosphate, the result is going to be that you accumulate galactose 1-phosphate. And that accumulation occurs in the liver, the kidney, and the brain. And those are going to be the three organs that are most affected. So the manifestation is going to be jaundice and hepatomegaly because of accumulation and damage to the liver, vomiting, seizures, and lethargy because of essentially the same way that the fructose 1-phosphate, the same reason that screwed up your gluconeogenesis. It's the same with the galactose 1-phosphate. It's going to inhibit gluconeogenesis. It's going to inhibit the breakdown of glycogen. And so you're going to have a hypoglycemia as well with classic galactosemia. So you have hypoglycemia, which can cause vomiting, seizures, and lethargy. It can also cause failure to thrive. They can get cataracts because all of that galactose is going to be built up into the blood. And then for some reason, they're susceptible to sepsis. We don't know why, but it's particularly sepsis from E. coli. No idea why, so you'll just have to remember that. And bulging fontanelle, that has to do with the fact that this galactose 1-phosphate is accumulating in the brain, it's drawing fluid in, and it causes them to have cerebral edema. Okay, so you can see, just by knowing the mechanism that you have galactose 1-phosphate accumulating in liver, kidney, and brain, you can see how all of these things kind of fit together. Okay, so here is our enzymatic block. And our workup is going to include a finger stick glucose because they tend to be hypoglycemic and they may appear so, CBC, BMP, liver function tests because a lot of these will have hepatomegaly, lactic acid, a uric acid. You'll want to get a head CT, especially if they have bulging fontanelles or they have seizures, and you'll get a urinalysis. And how is this going to come back? Finger stick glucose will typically show hypoglycemia. The CBC will usually be within normal limits unless they have some kind of fulminant infection, in which they may have an elevated white count. A BMP often will show metabolic acidosis because of that Fanconi-like syndrome because of the renal damage. Liver function tests will typically show an unconjugated hyperbilirubinemia from the liver damage. Lactic acid will often be within normal limits, and the uric acid will often be within normal limits. And the reason for that is because we don't have any problem with glycolysis here. And we don't have any problem with gluconeogenesis itself. We just have problems with some of those enzymes blocking gluconeogenesis when we're hypoglycemic. So we get the hypoglycemic episodes, but we don't have any problems with gluconeogenesis, with the enzymatic pathway of gluconeogenesis. So the liver has no problem detoxifying that lactate, turning it back into glucose, and clearing out lactate from the blood. So the lactic acid will be within normal limits. The uric acid will have no problem getting out of the kidneys. That will be within normal limits. The only exception to this, of course, is if you have sepsis, then yes, you can get a lactic acidosis from that. But from the disease itself, you're not going to get a lactic acidosis. A CT of the head may show some cerebral edema. Urinalysis should show some proteinuria if you have sufficient renal damage, as well as, of course, positive reducing substances from the galactose in the urine, because you have so much galactose in the blood, it's coming out the urine. The definitive test is a blood assay of GALT, and that's going to be low. What do we do to treat these patients? We're going to correct any emergent issues, and then we eliminate galactose from the diet. Pretty simple. The prognosis for these patients is a little bit different from the galactokinase deficiency. These patients will tend to have a pretty good prognosis provided galactose is avoided, but it's tempered by the fact that you do have some endogenous production of galactose. So your body makes some galactose for reasons I don't really understand. And then that galactose, you won't be able to break that down. And so that can be a little problematic, and that's going to lead to a little bit of disorder, even though they may take all the galactose out of their diet. For some reason, 80 to 90% of female patients with classic galactosemia will have a hypergonadotropic hypogonadism, and they will ultimately go into premature ovarian failure. Most of these patients will be infertile. And then speech disorders tend to happen in most of these patients because of some residual brain damage, and then occasionally they will have some impaired motor function and balance issues. Okay, and that's all I've got for you with fructose and galactose metabolism. If you have any questions, go ahead and write me a note below. Our next topic will be the pentose phosphate shunt.